Okay, so it is about 3 o'clock Eastern. Let's go ahead and get started. My name is John Mann, and I'm an assistant professor with the North Central Regional Center for Rural Development. So welcome everybody to our webinar today. The title is Mental Health Promotion, an Opportunity for Opioid Overdose Prevention. This webinar is part of the Rural Health and Safety Education webinar series, Combating Opioids. So I want to give a special thanks to our partners and series host, the Purdue University Extension, and I want to let you know that this series is part of a USDA NIFA and Substance Abuse and Mental Health Services Administration grant. Before we get started, I want to point out a couple of things. So one, if you haven't done so, take a moment and answer our poll questions for us. We appreciate your feedback. We'll also pop these up at the end of the webinar. Next, we are recording this webinar, including the question and answer session. So if you'd like access to the recording, we'll have it posted on the NCRCRD website in the next couple of days. And finally, there's a chat box to the right of the screen. As your questions pop up, please go ahead and put those in the chat box, and we'll get to your questions at the conclusion of the presentation. So once again, thank you everybody for participating today. Our presenter is Dr. Laura Schwab-Reese from the Purdue University, and she's going to share more about the opioid overdose prevention effort. So Laura, the floor is yours.
Terrific. Thank you so much, John. So I'm going to make an assumption, and I think it's a pretty safe assumption, that everyone in the webinar today is either interested in mental health or opioid overdose. And so if you're not interested in either of those things, this may not be the most interesting for you. But I also recognize that there may be folks who are familiar with and interested in mental health promotion, but aren't so familiar with opioid overdose prevention, and vice versa. So I'm going to start today by giving just a general state of where the United States is with mental health and where we are with opioid overdose and more broadly drug overdose. So I'm then going to move into a little bit about my work in this area and what we found, and then I'll wrap up with some practical recommendations. I always like to ask myself, so what, as I'm giving presentations and as I'm doing research, and so I'll wrap up with the so what. So at several points throughout this presentation, we have natural transition points. And so if you have questions, feel free to ask those at that natural transition, or feel free to wait until the end. So with that, let's dive in. So I'm going to start by focusing on drug overdose in the United States. And the question that I ask is really, how bad is it? I think that it's hard to listen to the news or read anything on the internet without hearing that drug overdose, opioid overdose specifically in the United States, is an epidemic and it's in crisis. And so when I looked at globally, what I found is that proportionately, the Americas and Europe have the largest proportion of deaths attributed to drug use. So about 25% and about 27% of deaths in Europe, in America and in Europe respectively, can be attributed to drug use. And this includes both overdose, but also other consequences of drug use, like HIV, hepatitis C, things like that. And the good news for some of you, although the bad news for others of you, is that it's not constant across the United States. There are actually some areas that are doing much better than average. So you can see that the Pacific Coast is doing quite well. Those states have opioid death rates much less than the United States. There's this lovely little section down the middle of the country from North Dakota to Texas that is also doing much better. But where I am in Indiana and some areas around me are doing quite a bit worse than average in the United States. And the bad news is that this is actually getting much, much worse. And so you can see that the dark brown line here is the total. So this is the age-adjusted overdose rate per 100,000 persons in the United States. So in 1999, our overall drug overdose, this is not just specific to opioids, but our overall drug overdose death rate was hovering around 5.5%, 6%, or 6. I'm sorry, that's not a percentage. But by 2017, we're actually more than quadrupled our rate. And so there are now 20 to 22 persons per 100,000 who die from an overdose every year. And we can also see that the proportion of drug overdose deaths that can be attributed to opioids is increasing substantially. So in 1999, about half of all overdose deaths could be attributed to opioids. But by 2017, I was incredibly surprised that the number of deaths that could be attributed to opioids were actually greater than the overall opioid overdose, or the overall drug overdose death rate for much of the early 2000s. And if you have been paying attention at all to opioid overdose in the news recently, you've probably heard about synthetic opioids, specifically fentanyl. And so you can see that across the different types of opioids, the death rate differs. So they're all around the same starting in 1999, but we can see that natural and semi-synthetic opioids, the death rate associated with those is increasing, but it's really in the last few years that the death rate associated with synthetic opioids other than methadone has really skyrocketed. And part of that is related to fentanyl. And so fentanyl, this picture shows you the lethal dose for heroin compared to fentanyl. And so I had to look really hard. It's just those tiny little grains at the bottom of the fentanyl bottle. And so it requires very little fentanyl to be a lethal dose, but also it requires a greater dosage of Narcan in order to reverse the effects of the overdose. And part of that is because fentanyl binds more closely to the receptors than other opioids. And so it's a bit of a double whammy where it's not only a lower dose that's necessary for a lethal dose, but also that much more Narcan is required. And so when I step back and ask myself, how bad is the drug overdose situation in the United States? It's pretty bad, and we're seeing that it's getting quite a bit worse. And so transitioning now into what's happening with mental health in the United States. And so you can see on this figure how the United States stacks up against other countries around the world as far as the percentage of people in the country who experience a mental health condition. The United States really sticks out as being very bright red, which indicates a higher rate than the other colors. Australia is also having some trouble, and Greenland is also has quite a higher rate than many other countries. And so when we look in the United States at the prevalence of mental health disorders, anxiety disorders are the most common. Almost 20% of Americans experience an anxiety disorder, followed by major depression. Bipolar disorder, schizophrenia are much less common, around 1% for schizophrenia, around 2 to 3% for bipolar disorder. And we can also see, unsurprisingly, given what we know about health disparities, that the mental health, the proportion of people who experience a mental health diagnosis differs by race. And so you can see that it's particularly the American Indian and Alaska Native population experiences a particularly significant disparity, with almost 30% of American Indian and Alaska Natives in the United States having symptoms that are consistent with a mental health disorder. The good news, if I can bring a little bit of good news to this, is that the number or the percentage of adolescents in the United States who experience depression symptoms in the past year is slightly increasing, but it's not increasing in the same way that we're seeing some of these other health outcomes. The even better news is that among adults in the United States, the lifetime depression diagnosis percentage is actually decreasing. So we've been around 17 to 18, 19%, and in 2016, which is the most recent numbers that I could find, we're actually back down to where we were in 2011. Good news for adults, not such great news for adolescents. Many adolescents who could benefit strongly from mental health care don't receive treatment. It's almost, I actually had to check this figure to make sure that I didn't enter it backwards, but it's almost inverse for adults. So about 2/3 of adolescents who need mental health care do not receive it. And inversely, about 2/3 of adults who have a significant mental health issue do receive treatment. So again, we have a little glimmer of good news there. And so there's actually a really great resource on mentalhealthamerica.net that compares the state of mental health by state, and it includes all of these different factors. So it's things like what percentage of American adults have mental illness, substance use, serious thoughts of suicide. But what I really like about it is that it also considers who has a mental illness and reports unmet need, meaning that they weren't able to get treatment, who had a mental illness and did not receive treatment, how many folks are uninsured, how many people can't see a doctor due to cost. And so it's a really very comprehensive look at how holistically people in each of those states are doing as far as mental health. And so when we look at the overall ranking, and then I'll break this down by adolescents and by adults, like I said, I'm in Indiana. We are unfortunately a little darker spot amongst a sea of fairly light spots. Overall, the Midwest tends to be higher ranked than some other areas, with the exception of Indiana. We see that the mountain region, Colorado, Arizona, Nevada, Idaho, those are areas that tend to be doing poorer as far as that kind of holistic view of mental health. When we look at adult mental health rankings, we see that, again, unfortunately, Indiana is sticking out a little bit more, but that similarly, the mountain region, Washington, Utah, those states tend to be lower ranked than some of the other places in the Midwest. A slightly different picture for adolescent mental health rankings, although overall pretty consistent with adults. There's my poor Indiana sticking out again. And when we look at mental health provider shortages, so this figure shows you ranging from the white to the very dark black. The white end of this spectrum is states who have a higher percentage of their mental health provider needs met. So it tops out, I think it was about 70% of need met, all the way down to the black, which is the lower range, and it was really quite low. And so these are areas where people who need and people who are seeking mental health care may not be able to receive it. You can see that there are areas that are quite consistent with the previous rankings, New Mexico, Arizona, those places. But fortunately for Indiana, we're not in the far black for this one. Just a quick note, Vermont didn't report data for this, and so they are tan because we don't know how they're doing. And fortunately or unfortunately, depending on where you are, this isn't consistent across within each state. And so this is the mental health provider shortage in Indiana. And so the red indicates places that don't have enough mental health providers in the geographic area. The green is low-income population folks who may not be able to access mental health care for cost reasons. And so you can see that there are areas in Indiana that have sufficient or nearing sufficient mental health providers, and there's large areas that don't have sufficient numbers of mental health providers. And so overall, when we take a step back and look at the overall impact of mental health issues in the United States, about 10 million Americans report severe psychological distress in the past month. About 44 million Americans experience mental illness each year. That results in almost 60 million office visits every year, almost 6 million ER visits, and 42,000 suicide deaths. And so when we take a step back and say, what is really the state of mental health in the United States? It's not great, particularly when we compare ourselves to other places in the world, but it's fairly stable. we aren't seeing significant increases or substantial increases, I should say, in some of the ways that we're seeing opioid overdose deaths spike. And so I like to take a step back and ask, really, what is it that influences mental health and addiction? I don't remember if it was shared. I have a background in mental health. My master's is actually in counseling. I did that for a little bit and realized that I was really very interested in the community focus. I wanted to know what I could do on the broad scale to help lots of people, although clearly that one-on-one connection with mental health providers is incredibly important. So when we look at what influences mental health, we see that it's genetic and biological influences combined with environmental factors. Unsurprisingly, we see it's exactly the same for addiction. And there are a lot of overlaps. So when we look at mental health, the causes of mental health issues, we see that it's certain genetic factors, it's environmental exposures before birth, and there's some aspects of brain chemistry. And so I'm going to take a minute as someone who also has some training in epidemiology to say these are the causes. These are the things that we can pretty conclusively say these are necessary and or sufficient to cause a mental health issue. I'm going to go into risk factors in a little bit, and those are things that increase the likelihood that people will have a mental health issue or an addiction issue, but they aren't necessarily in the causal pathway. So we can see that, again, with addiction, genetics have a significant, are part of the causal factor, part of the causal pathway. Environmental factors are also quite important, although they're different from some of the environmental exposures that are necessary and or sufficient for mental health. We also see that there are some physical changes that occur in the brain that can cause addiction to either increase or to begin. And so when we look at risk factors for mental health issues, things like stressful life situations, chronic health issues, trauma, social isolation, and alcohol and substance misuse are all risk factors for mental health issues. And unsurprisingly, we see lots of very similar things for addiction and family history, mental health disorders, peer pressure, lack of family involvement, early initiation or early use, and certain characteristics of the drug can influence whether someone is more likely to experience an addiction. And so a couple of years ago became very interested in marrying the two sides of my career, the mental health and the public health, and realized as I was coming to Indiana that opioid overdose deaths and opioid overdose in general was something that was very important for me as a community engaged researcher and as a community engaged health, public health practitioner to understand. And so when I was in Colorado, actually decided to look at could the increase in opioid overdose deaths be attributed in some way to mental health? And we decided ultimately to operationalize that as depression, in part just because that's the data that we had available. But more broadly, our question is mental health contributing? Is it driving some aspect of the opioid overdose crisis? And so when I actually dug into the literature, there was a very interesting, several very interesting articles on the biological underpinnings of depression and opioid overdose. So there were, I want to say the animal was mice. There were several mouse models that suggested that if you had a mouse who was experiencing depression, there were higher rates of initiation and chronic use of opioid analgesics. And the flip was also true, that the chronic use of opioid analgesics could increase depression symptoms. And so this was repeated in just a couple of, or parts of this were repeated in just a couple of human studies. And we only found one study that actually looked at opioid overdose deaths rather than just opioid overdose. And so we used, if you're not familiar with CDC Wonder, I would strongly recommend Googling CDC Wonder and looking at what comes up, because they actually provide tremendous information about what's killing Americans and what's killing Americans in each state. And so you can really dig very far in and get very specific. And so we used CDC Wonder to look at 3 different types of opioid death outcomes. So we first looked at deaths and the death rate in each state that was only attributed to opioid analgesics. We also looked at unintentional opioid analgesic death rates. So this was specifically excluding suicides and other homicides, things that people intentionally do to other people. And finally, we looked at all opioid-related deaths, and this includes illicit opioids. So those were our outcomes. That was what we were trying to predict, and the exposure that we used was BRFSS or BRFS data, which is a telephone-based survey of Americans in every state. They ask, again, if you're not familiar with BRFS, this is another terrific resource to understand what's happening in your state. One of the questions asks, have you been diagnosed with depression by a mental health provider? And so we used as our exposure the percentage of the state population with self-reported depression diagnosis. And we also controlled for a number of things, including overall state-level reports of health. We thought that perhaps people who are in states who are overall less healthy may be more likely to use opioids. They may also be, let's see, we also controlled for percent of insurance status. So basically how many people in the state have insurance. We also controlled for medical marijuana policies, because there's a small but growing body of literature that suggests in some areas medical marijuana is being substituted out for opioid use. And so we thought that was something important to understand also. And so basically after we control for all of those things, meaning that we tried to discount the impact of those things on the relationship, we found that for every additional percentage of the population who reported depression, there was about 26% increase in the number of opioid overdose deaths. So this is the opioid analgesic deaths. We actually found a greater impact on unintentional deaths. So for every additional percentage of the population in the state, so let's say we moved from a state who had 25% of the population who was depressed compared to a state that had 26% of the population that was depressed, we would expect that second state to have about 31% more unintentional opioid overdose deaths than that first state. We found very similar results for all opioid-related deaths, so those are the ones that include illicit opioids, and about a 33% increase there. And so the bottom line was for every 1 percentage point increase in self-reported depression diagnoses, we saw a 26% increase in opioid analgesic related deaths, which is really a substantial number of deaths. And so I always ask myself at the end of doing research, or often at the beginning of doing research, so what? What do we do about this? It's great to have additional knowledge, but what can we actually do? And so in digging into the literature, we found that nearly 2/3 of opioid overdoses involve prescription opioids. That doesn't necessarily mean that they were prescribed by the doctor, but they are opioids that are able to be obtained through a prescription. And so something that we think has the potential to influence opioid overdose death is conversations in the patient-provider relationship. So we think that there's the opportunity to conduct initial and ongoing depression screening. This is something that many doctors' offices, many healthcare providers have already implemented. We also think that there's an opportunity to discuss the risk for depression as people are prescribing opioids, and also share information in that moment about the risk for depression, opioid addiction, and how to seek help. Now, we also realize that healthcare providers have a very limited amount of time now to see patients, and so there may be it may be important to engage with other professionals for those conversations, and then have other professionals have those conversations with the patients. But we think that because of both the mouse models, the human models, and now our results, we think that it's important that patients understand that taking opioids may increase their risk for depression. We think that it's also important for patients who have depression to understand that relationship with opioid use. Finally, in the United States, only 44.2% of the mental health care need is met. That means that less than half of the mental health care need is met. And so in digging in, this is not, I can say that we need efforts to train and retain mental health providers, but people much more informed than I did came up with these recommendations. And so you can actually go to the nationalcouncil.org, and they have tremendous recommendations for how to support efforts to train and retain mental health providers. Something that they encouraged was incentivizing workforce development, which basically means that we need to encourage folks to become mental health providers. So when I was in Iowa, there was a program that paid or reimbursed physicians who were willing to practice in rural areas for their medical school loans. And so that was one way that Iowa incentivized rural physicians. And so similar things could be done for mental health providers. There's also a need to reduce the regulation and the reimbursement burden. And so what the report that I am referencing said was that mental health providers spend an inordinate amount of time managing regulations and managing the reimbursement process. And so it's not that we shouldn't have reimbursement, it's not that we shouldn't have regulations, but it's rethinking how can we help mental health providers spend more of their time providing care, more of their time doing what it is that they got into the profession to do, and less of it submitting and resubmitting and then maybe resubmitting reimbursement claims, managing regulations. The report also had some really interesting recommendations as far as innovative approaches. And so part of the problem with mental health access is that it's geographically difficult to get to. There's also a cost barrier. And so potentially providing mental health services in innovative ways. So alternative clinical practices, for example, where people may not be practicing in what we would think of as a clinical space, but rather practicing in the community at perhaps a YMCA or other places that people who need the services can easily get to. Telemedicine also came up quite a lot here, and this actually ties in with the next one, which is increased reimbursement or novel reimbursement methods. So many states at this point don't allow for reimbursement, or I guess I should say many insurers. I don't know that it's a state policy. Many insurance providers don't allow reimbursement for telemedicine when it comes to mental health. And so we can increase access, assuming that there is sufficient internet access, which is a big assumption in particularly rural areas. But assuming that we could get folks access to telemedicine, telemental health services, allowing for reimbursement would be a significant factor in whether people take advantage of those approaches. The report also suggested that just generally increasing reimbursement would be another way to support efforts to retain mental health providers. And so those are broadly the things that we as a community can do. So we as a community, we as folks who are providing mental health care or physical health care can have conversations about this issue. We can also support efforts, whether that means calling an insurance provider or calling a policymaker, but in some way supporting efforts to train and retain mental health providers so that we have a greater percentage of the mental health care need in the United States met. Now, I'm going to transition a little bit to what you can actually do. And so this focuses a lot on mental health first aid, if that's a phrase that you're familiar with. If it's not, it's basically what can people who are not mental health care providers or not otherwise trained health providers do when they suspect someone is having a mental health issue or a mental health crisis. And so the first thing that's recommended is assessing for immediate risk of harm or suicide. There's some warning signs, things like talking about wanting to die. The person is talking about wanting to die. The person is talking about feeling hopeless or helpless. They're talking about being a burden. You're seeing that they're suddenly withdrawn, or they're experiencing extreme mood swings, or they're engaging in reckless behavior. Those are all warning signs that someone is at risk for suicide or self-harm. And so if there is an immediate suicide concern, there are several things that people can do. They can call 911. They can call the National Suicide Prevention Lifeline. And something that I like to recommend while you're waiting for those things, those resources to come into play, is doing what I call a 5-4-3-2-1 coping exercise. And so it's a way to help people come back into the moment and to reduce kind of the emotional intensity of the situation. And so it's very simple. You ask the person what are 5 things that they can see, what are 4 things that they can touch, what are 3 things that they can hear, what are 2 things that they can smell, and what's 1 thing that they can taste. And so that's one way to bring back the person into the immediate moment. If there aren't immediate suicide or self-harm concerns, then more broadly, listening without judgment is important. So when I was trained in counseling, we called these kind of the micro-counseling skills. These are the ways that you tell people that you're listening, you tell people that they're important without using words. So it's maintaining eye contact. It's positioning your body in a way that is open. You're not sitting with your arms crossed, your legs crossed, kind of hunched away from the person. You're keeping a calm voice tone. You're talking at a calm pace. And using open questions to encourage people to talk. So these aren't the do questions. These are the whats, the hows, the coulds, the woulds. And so these encourage people to share or to talk about what they want to talk about without closing off their opportunity for response. More options. These are a little bit more advanced, but you can paraphrase what you're understanding people are saying or people are thinking. It's fairly straightforward to do so. You can kind of add a buffer to the beginning, saying things like, it sounds like you're saying, and then reflecting what it is that you, or paraphrasing what it is that you heard them say. You can also reflect feelings back to them. It seems like you're feeling X, it seems like you're feeling Y, or it seems like you're feeling or you felt X when Y happened. And so this is a way to help people better understand their own feelings. So if you reflect that it seems like people are feeling horrible, it's the worst day of your life, and that's not the case, then it helps people reflect back that maybe it's not the worst day of their life. Maybe it's just a really bad day. Finally, reassuring or providing information. So mental illness is still quite stigmatized in the US. That's shown by how mental illness is portrayed in the media. It's the assumptions that we hold about mental illness. There are innuendos that many people make about mental illness. It's actually physically removing yourself, physically stepping back from individuals with mental illness, or disrespecting the severity of the mental illness. And so while it's difficult to make broad sweeping cultural change around stigmatization, it can be helpful to be aware of what you may be doing in those moments that may be perceived or actually be stigmatizing. Also encouraging people to talk with a professional. There are limits to what a friend or a family member can do as far as mental health first aid, and so if the person that you're talking with needs to talk with a professional, it's encouraging them to do so. At times, it may be helping them go on the internet and find that mental health provider. It may be sitting with them while they call the mental health provider, or the doctor, or the peer specialist, and really not only encouraging them in words, but also showing your encouragement through actions. And finally, encouraging people to engage in self-care. Self-care is a big buzzword that we're all probably hearing a lot about, but it doesn't have to be expensive. It doesn't have to be that you jet off for a vacation in the Mediterranean. It can be small things like encouraging people to take a couple minutes at the end of their day to focus on their breathing, or whatever it is that that person finds helpful is what will work for them. So my research group focuses a lot on not very happy things. We do a lot of work on family violence. We do a lot of work on suicide. We do a lot of work on opioid overdose deaths. And so I ask my students as they start working with me, what fills your bucket? And so they often look at me very confused and they don't know what I mean by fill your bucket. And so I then go on to explain that if you think about what makes us excited, if you think about each person having kind of an emotional energy to them, you have those moments when you are feeling really good. You're feeling like you are on top of things, you are happy with what you're doing. Some people call it flow, where you're so immersed and so engaged in what you're doing that it feels like time just stops for you. But we also all have probably experienced times when our bucket feels low, and so we may be dragging. It may be difficult to get up and go to work. And so by asking students what fills their bucket, by asking the people who work in my research group what fills their bucket, I'm asking them to start thinking about what is it that works for them. And I found that almost everyone has a different response. And so in the moments that our research is particularly challenging or it's particularly emotionally draining, I can go to that student or that researcher and say, it seems like this is really weighing on you. I completely understand. This work is weighing on me also. It seems like I remember that going to a movie with your best friend is something that you really love doing. Do you have time to do that in the next couple days? And so it's making very explicit that engaging in self-care isn't selfish. It's something that we all need to do when we're engaging with emotionally difficult or mental health issues. So that is what I have for you all. I'm happy to answer questions. I'm also happy to answer questions via email if you would prefer. My email is listed on this final slide. Otherwise, I think we can take questions in the chat function. So with that, I'll go ahead.
Great, thanks. Yeah, thanks, Laura. Sorry, I didn't mean to cut you off there.
No problem.
If you want to make it helpful, I can read the questions and then give you the opportunity to kind of go through some of your slides to reference those. So the first is, David had actually a question that popped up at the very beginning of the presentation, and so he was asking about the environmental risk factors. And so it might be maybe just if you can find that slide and just kind of revisit those for a moment, and then I'll read the next question.
So does it say causes or risk factors?
Environmental risk factors.
Okay, trying to find the right slide. So it actually may have been on one of these two slides. But basically, for both mental health and for addiction, we know that there are environmental factors that influence not necessarily the cause, but the likelihood that someone will have a mental health condition or an addiction issue. And so they can be a little bit different depending on whether it's mental health, and I have really very overgeneralized as mental health and as addiction. We know that there are differences across types of mental health issues. We know there are differences with types of addiction, alcohol versus other substances. And so the environmental factors themselves and also the genetic and biologic influences themselves are going to differ a little bit depending on which specific outcome we're talking about. But in general, we know that, and I know a lot more about this little piece because it's very close to my area of research. We know that your family of origin experiences are very important. So we know that trauma in your family of origin, whether that is child abuse, whether that's neglect, whether that's witnessing violence between your caregivers, whether that's just ineffective parenting that doesn't rise to what we would consider in the United States to be abuse or neglect. We know that that influences the risk for mental health issues and also for addiction. We also know that, at least for mental health, the environment, the stress that someone is experiencing or the stressors that they are experiencing in their environment can exacerbate mental health issues. I believe that's the same for addiction, although I don't know that literature quite as well. We also know that perceptions about acceptability, specifically related to addiction, perceptions about acceptability of addictive behaviors or of substance use can influence whether people are going to take them. I think I specifically called out peer pressure. So if you are a young person who thinks that everybody's doing it, it's no big deal, my best friend does it, my older brother does it, then you're more likely to start using. And we know that people who start using early are more likely to develop addiction or misuse issues. So I hope that answered the question, and I'm happy to clarify if it didn't.
Awesome, thank you for that. So again, in the audience, if you have questions, go ahead and type them in the chat box. So the next question asks, are there significant studies underway in the state of Indiana with respect to the efficacy of miracle marijuana, as a viable fix for addiction or substance abuse?
So I'm not familiar with anything specific to Indiana. I actually, a couple of years ago, did some work on if states that had medical marijuana policies had lower rates of opioid overdose deaths. And I didn't end up publishing it because the results depended entirely on how I specified the statistics. And so if I specified the model in one way, it showed that medical marijuana was protective against opioid overdose deaths. If I specified it a slightly different way, it was the opposite. And so I think that it's something that we definitely need to study more, because right now there's a lot of assumptions from some small studies, but I think there does need to be much broader scale studies as to whether or not medical marijuana or recreational marijuana could be a potential option for reducing opioid overdose.
Okay, thanks for that. So the next question is actually asking for the website you mentioned regarding the mental health professionals. This is for the retaining mental health professionals. So I guess we can type that into the chat box.
Yep, I will type that in right now. And the link that I'm going to share actually takes you directly to the PDF. But if you did that send?
Yep, I can see it. Great.
Perfect. So that takes you directly to the PDF that they talk a lot about psychiatric shortages and potential efforts to reduce those. But the nationalcouncil.org their general website also has a lot of really good information.
Okay, great. Thank you for that. Okay, so next question is a little bit long and in a couple of parts, so I'll just I'll get it all out, and then we can go back and revisit. So you said nearly 2/3 of opioid overdoses involve prescription opioids. What year was that data? The next part of the question is this shifting with policies changing in how prescribers prescribe opioids? What might this mean as prescriptions become more difficult to obtain for opioids and people who are addicted shift to the street drugs such as heroin?
Okay, I'm looking to find the citation for that data. And so it looks like, and I will type into the box that citation. So that the 2/3 of opioid overdose prescription opioid comment was from a 2014 article in JAMA Internal Medicine. I haven't seen more recent data than that. I can guess that things are changing as far as percentage of folks who are using, or the percentage of deaths that involve prescription opioids. And part of that is based on my own community engaged work in Indiana. We're seeing in the communities that I work in that as prescription opioids become more difficult to acquire, people are using other opioids or other drugs in general. So I would expect that that is changing, but I don't have empirical data to support that assumption.
Okay, thank you for that. Okay, so the next question asks, is the connection between mental health and opioid misuse consistent across different communities? For example, Native American, African American, LGBTQ+, pregnant mothers, etc.
Ooh, that sounds like a really good research study. As far as I know, there haven't been those studies on specific groups. Part of that is because it's hard to get that data. So in using the CDC Wonder, we were able to look at state level estimates, but it's much harder to get state level estimates or to get access to individual level data that would allow us to look at specific subpopulations. But it's a great research question. I would love to know the answer.
Okay, thank you for that. So I've got a question for you myself. I'm an economist, and I always appreciate working with data and data differences. You had a map kind of early on that showed globally the mental health related reporting, and I was just curious, just based on my experience working also with international students and thinking about the stigma related to mental health. I wonder if you can speak on anything about, either is this a reporting thing, is this a stigma thing, are there really those kinds of differences? Is this related to maybe more developed nations? What might contribute or account for this kind of stark difference between the U.S. and, say, Australia and or North America and Australia and the rest of the world?
That is a terrific question. And so I pulled this data from the most recent I think it was the most recent WHO. The link is at the bottom there. And I can't remember how they conceptualized mental health. I think it was diagnoses. And so then very much so, I think stigmatization could influence that. I mean, we see that among gender differences with mental health, that in many areas, women are more likely or more willing to go to a mental health provider and receive a diagnosis, but that doesn't necessarily mean that the underlying symptoms are different. We also see, and now I'm just getting off on a little bit of a tangent, that mental health presents differently among men and women, and so that might be driving a little bit of the differences in diagnosis also. But I think you're probably right that stigma influences who's going to be diagnosed. I think mental health care access also influences who's going to be diagnosed. if you don't have access to a mental health provider, or if your cultural background doesn't emphasize mental health, or you have different than Western perceptions of what is a mental health disorder, then that will all influence diagnosis. So I think that there are probably still differences. And I think part of that can be supported with the increase in suicide that we're seeing in the United States, that it's not just the change in perceptions of stigma associated with mental health that are driving longer term increases in mental health diagnoses, but that there are also some underlying changes that are happening. So I think the answer probably lies somewhere in the middle, that there are differences, but they're probably not as stark as they appear on this figure.
Okay, thank you for that. So scanning through, it looks like we got to all the questions. Looks like Jim added another citation. So looks like we'll be close to wrapping up. In doing that, Laura, any parting thoughts? I know you've touched on a lot of different things, but is there a thought you want to leave with the audience?
I guess, and this is a thought that I leave most presentations with, that I do like this, and that's that sometimes it's easy to feel like you as an individual can't make a difference in issues like this, but there are ways that you in your daily life, and I touched on these in the presentation, ways that you yourself can impact this issue. So even if you don't feel comfortable calling the legislature or advocating for changes to insurance companies, you yourself probably interact with people who are having mental health issues. You probably interact with people who are experiencing addiction issues, and so you can change the way that you interact with them.
Okay, great. Well, thank you for that. Again, if you would like a link to this recording and the slides, those will be posted on the NCRCRD website in the next few days. So in closing the webinar, I want to say thank you to our presenter once again, Dr. Laura Schwab-Reese from Purdue University, and thank you in the audience for participating. And with that, we will conclude this webinar.
Thank you so much.
Or if you're still there, we got a question that kind of popped on after we closed things out. I don't know if you want to make an attempt to answer that.
Yeah, yep, I'm still here.
Okay. At the very bottom, so it's during a recent doctor's visit, I was asked if I was having any thought of suicide. Is this becoming a national trend?
I can't speak as far as national trends, but I do know that there is a lot more emphasis on screening at primary care providers. So there tend to be a focus on screening for depression, for suicide, and many doctors actually are now also screening for violence or safety of the home. And as far as I know, we don't have a lot of data to support these efforts as far as evaluation, but on the front, it makes a lot of sense that knowing about the issue helps doctors provide care and to connect to resources. So I would expect that we'll continue to see that become more present in doctors' visits as these issues continue to be an issue.
Okay, great, thank you. All right, and with that, we will call it now.
All right.
Officially closed. Thank you so much.
All right, thank you.